Hi, everyone. Thanks so much for joining. I'm really proud to kick off this webcast. My name is Rob Messmer. I'm the Vice President of Sales and Channel Chief for CBTS. And we put this series together, or this webcast together, for our partners. I think we had at kind of last call on the registration, well over 100 partners registered. So thank you for joining. We have this presentation is really to help enable our partners in how they talk with the healthcare vertical and how our technology enables that healthcare vertical. Our presenters today are Dustin Leak, who runs our healthcare practice, as well as Matt Douglas, that many of you may know, who runs our sales engineering for the channel. And this is really a setup for a series that another webcast that we're going to have on the 20th of May, which is really customer facing, where you should feel free to invite your customers to hear a similar message. Obviously, this is geared towards our trusted advisor partners and that ecosystem that's so important to CBTS. But the one on the 20th, again, is really for you to invite your customers. And when you do that, there will be a place for you to say that you're referring a certain customer, and you can, and then if they sign up, they can put you as the referrer as well. We've made a very conscious effort to invest in healthcare about 3 years ago. So as COVID-19 started happening, we felt that fortunately we had prepared and put a lot of seeds in the ground for not only investments in technology, but also for investments in understanding how the healthcare vertical operates in technology. And one of the key cog to that was an investment we made with Dustin Leak in terms of his expertise, and he joined the organization a little less than 2 years ago. So that's who you're going to be hearing for in most of this presentation, really around the healthcare vertical. A couple housekeeping items. We're going to have, they gave me a list of things to read off to you. Q&A, please type that Q&A into the chat window, and we will read those off. Gabby Scott will take care of those duties. This is being recorded, so we'll be able to send it along with the slides out later. And if you have any questions, follow up with your channel manager. All the channel managers are up to speed on this presentation and attending. And so any questions you have, you can follow up with them. So with that, I'd like to introduce Dustin Leak. Take it from here, Dustin.
Thanks, Rob. So as Rob mentioned, I'm Dustin Leak. I lead our healthcare practice vertical. This is a picture of my beautiful mug in case you guys can't see me on video. But more importantly, it speaks to the investment that Rob had mentioned earlier in the healthcare, in building the healthcare practice. So prior to coming to CBTS, I spent 15 plus years working in all areas of healthcare IT. And the final 6 before joining CBTS were as Chief Technology Officer for a large integrated healthcare delivery network in Central Florida. For those of you not familiar, an integrated delivery network just means that it has hospitals, that has outpatient and specialty, but also includes an insurance company. So it gets kind of the mix of both worlds there. My experience working with children's hospitals, safety net hospitals, as well as just general nonprofit hospitals, prepared me, I think, very well for this role, especially my role with CBTS, because I was transitioning our organizations from a large on-prem to large-scale cloud practice and future for us. You'll see a little bit more consulting experience in my past life. Silicon Valley startup, which was a very fun and interesting job to have, especially coming right out of the Army into it. So from very structured to very unstructured is the way I like to describe that. So the practice for CBTS really is centered around 3 main objectives and principles. And I like to say there's a fourth one, and it's really this client first approach, which I'm sure all of you have a very similar approach to your customers, as you talk with them and meet with them and provide solutions, right? So it's really about partnership, is kind of how I sum this up. If I'm looking at my partner or my agent or channel as a partner, or my end customer as a partner, then I'm going to make good choices for them, that will ultimately reward me. I think the other thing I'd like to call your attention to on this slide is the HIMSS North America Diamond corporate level member. For healthcare, HIMSS is very important. It's where we go to find out what are our peers doing, what do we think is coming up in the next 3 to 5 years strategically, what should I be thinking about. So for CBTS to contribute to the HIMSS environment and collective was very important. We're allowed to feed back into HIMSS. We're allowed to pull out of HIMSS. And most importantly, annually, HIMSS has a very large 50,000+ person event, usually in Vegas or in Orlando. We're allowed to bring and present to our customers in that setting as well. So just really, if you're not part of HIMSS, it's very hard to get that first look without a relationship. So, as I mentioned, there are 3 practice objectives for the healthcare practice. The first is to support and enable customer leadership. So in this role, I spend a lot of my time, I should say, pre-COVID time, on airplanes flying around, meeting with our customers, IT executives, help build strategy, meeting with our channel partners as well. So I'm a resource to you, and really explaining what's going on in healthcare, sharing what we're seeing from other customers. Healthcare is very focused on what everyone else is doing and not necessarily being the first to do something new. So sharing what we're seeing from other customers, as well as learning from our customers and our partners. And then secondarily, consulting CBTS product teams. Well, actually, let me back up. So an example of how I support and enable customer leadership: we have a large health system, we'll say in the New York metro area, that I help their IT leadership build out a 3 to 5 year roadmap. So, for example, I sit down, I spend time with them, they're open with me, and they tell me, here's what I'm thinking about. And it may not even be something that CBTS does well, or even something that's IT related. It could be very business and clinical related. And we build out this roadmap. I feed it back to them on their paper, and then they in turn update it, and they've got this tool that's available to them, which is their roadmap. When I was CTO, my issue with roadmap sessions or strategic planning sessions were that there were always a half day offsite, a mix of learning, talking, team building with the entire IT executive leadership team. And then we'd come back into the department, and the next day it'd all be thrown out the window because we'd be back to firefighting. So in the example I was mentioning about the large New York metro healthcare customer, I helped them build out their strategy. I put it on paper, their paper, I feed it back to them. And then, oh, by the way, on the backside, I'm shipping that off to my account rep or my partner agent to say, I'm not sure if you're aware of the full landscape, but here's what it looks like based on my conversation with them. It gives us a unique insight to what they're planning, as well as allows us to help them through my experiences along the way. So the second objective for the healthcare practice is to consult CBTS product teams. So every product that we have, whether it's a managed service, it could be as simple as marketing if you're talking about an infrastructure product, but managed service, hosted service, I review those, I look at them, I help determine from a marketing perspective, how do we market this to healthcare? From a feature perspective, is there anything missing that healthcare would need in order to kind of make the leap into this product? As well as then using our industry trends to influence future product design, to say, or features even. If you look at a managed service product, I think one of the best examples I can use is from my real life as a CBTS customer. So we pushed all of our telephony platform, all of our telephony endpoints, over 14,000 of them, onto CBTS's hosted enterprise unified communications product. And through that process, as a customer, I figured out, hey, there's a little bit of a flaw in the way that incident tickets are prioritized, meaning that their CBTS at the time said, hey, look, if it's a single phone line, it can't be considered a critical severity incident. However, for me and many of the other healthcare customers, I had a single phone line in my insurance company that I had to report downtimes to the federal government. And if it was down more than 6 hours a year, it cost my organization $20 million. So I worked with CBTS then as a customer, but to say, hey, look, this is so important to healthcare that they'd be willing to pay extra money in order to have certain specified phone lines treated as a critical incident in terms of severity if something were to go wrong with them. And the CBTS product team said, hey, that's a great idea. If they're willing to pay for it, we can cover the extra internal costs that are going to be associated with that level of service on a single phone line. And let's build it into the product set, and let's make sure we're talking about this with each of our customers who are considering it to say, do you have a list of telephone lines that we need to prioritize above all others? And then finally, building partner relationships. So that could be channel partners, that could be infrastructure partners, it could be software partners. An example that I use here is that while we could walk in and we could sell you a solution that includes most of the components for telehealth, for example, the first question that a healthcare CIO or CTO is going to ask me is, yeah, that's great. Now my doctors can connect with my patients, but what do I do about a virtual waiting room? Or how do I handle patient education while they're waiting in the waiting room? And unless we can deliver a full product, it's not really of as much benefit to our customers. So working with our channel partners, working with our software and hardware partners to identify opportunities where we can really bring a complete solution to market. So I'll pause there for a second just to check in to see if there are questions or not.
Nope, we're good. You can keep going, Dustin.
Oh, thanks, Gabby. So this is what I refer to as our NASCAR slide. These are just, these aren't all, but these are some of the hospital-based customers that we provide all of our products to that you'll see on the next slide. Some may just be traditional VAR, some may be managed services, some may be professional service, and some may be cloud service. But I think it's a pretty impressive set of logos when you look at and determine what the scope of CBTS's reach is, right? So you've got Alberta Health that's in Canada, you've got Baptist that's in Kentucky, you've got some Cincinnati locations, you've got New York City locations, Indianapolis locations, Ohio, other areas in Ohio, and I'm sure I'm leaving somebody off of there, Michigan locations. So I'll just kind of move on, but just on the next slide, we'll kind of get into some of the services that we're providing to these various customers. So this is what I refer to as the pretty slide here. It's really intended to be the single slide leave behind for all of our services and products from CBTS for a customer. So when I was in my old role, I would get these great decks that were like sometimes 20, even 50 slides long. And usually there were 1 or 2 slides in that deck that I would pull out of the deck, and then I would file the rest of the deck in the trash can as soon as the rep left my office. So the goal here was really to create the one slide that says, okay, when I'm thinking of CBTS or when I'm thinking of whomever, what is the one thing that I can look at and say, is this in the wheelhouse or not? So when you look at this down the left-hand side, you see some of our products and services, mostly services here. But on the right-hand side, it actually maps it to a care setting. So if you match up the DRAS or cloud or security lock looking piece to the care setting, which is home care here. This is your outpatient care for healthcare, and then your more of your imaging centers, so radiologies and specialists like an oncologist, hospital-based setting, and then skilled nursing facility. And then just to kind of complete the circle, back to the home care setting, which really helps lay it out. The goal is just to be a leave behind. Are there any questions on this slide before I move into different material around the CARES Act?
Nope, we are good.
All right, thank you. So the other intent of this presentation was really for me to talk to everybody about, we keep hearing about government funding for healthcare through the CARES Act, and as a result of the federal government's response to COVID-19, there's really two main areas that impact any healthcare customer that you might have. The first is just called healthcare funding through the CARES Act. This originally was $100 billion that was to be distributed by the Secretary of Health and Human Services, and then it was increased to a little sneeze there, and then it was increased to $175 billion in the middle of April. So the intent of this, I apologize, another one there. So the intent of this money is to reimburse more in a generic way healthcare providers for expenses or lost revenues related to COVID-19 pandemic. Now, the last statement there about or lost revenues is important to my final bullet there, which is it's not enough money. When you consider just one of our customers alone lost $300 million in the first quarter, another lost $600 million in the first quarter, you could see where that $175 billion is not necessarily going, when it could be, it's not going to be spent probably on IT purchases and equipment, because the hospitals are going to kind of hold back and see what their total losses are. By the way, those first quarter losses only included half a month of shutdown of non-elective services for healthcare. So I imagine when we see the second quarter numbers, you'll be able to see the full impact of a full month of shutdown, which was the month of April, and then for some states, parts of May. And then the second funding mechanism that's in there in the CARES Act is called the COVID-19 Telehealth Program. This is $200 million distributed by the FCC in reimbursements that allow for telehealth equipment, services to combat COVID-19. I'll kind of break these two down a little bit more so that you get a better idea and discuss some of the hurdles that we might have, and also some of the benefits that your customers would see in this type of funding. So the first one that we mentioned was the $175 billion. So who's eligible? Public healthcare entities, Medicare or Medicaid enrolled suppliers and providers, and then this generic kind of catch-all other for-profit, nonprofit organizations as specified by the HHS. Basically, these are organizations that do work with the first two bullets and have special classification by the Health and Human Services. So the way that it works, before I get into that, I will say it's not the one way to think about this. If it's a private healthcare entity, it doesn't apply. So some of these local area primary care physician groups and those, they wouldn't apply because they're not a nonprofit. They're an LLC or an S corp or something like that. So the way it works is that anybody in those top three bullets, they spend their own money up front and request reimbursement from the government afterward. So as we talk about the opportunity, some entities may seek reimbursement for hardware, software, services used in direct response to COVID-19. Now, the example I'd like to use here really is around hurricanes, which is not COVID-19. It's obviously has a lot further reaching impact. But in my prior role, I lived through and functioned through the organization through 7 hurricanes. These all start the same way. The federal government declares a state of emergency. The state then declares a state of emergency and then says to the federal government, we would like to tap into the federal emergency dollars. And then the healthcare entity then begins tracking expenses. So in the hurricane case, it was what expenses are associated with preparation, survival, and coming out of the hurricane. So it could mean care-based expenses. In my old life, I would use this as a way to get extra, remote or mobile licenses that we would need, because the response was always to send non-clinical, non-essential employees home. So if I needed new WebEx licenses, I would tap into this and you work through your purchasing department, who is usually the person, or your accounting department that's tracking these expenses. You could also use it for adding new technology that maybe you wanted to try out, right? So we'll get into this a little bit more in the telehealth slide, but think of it as, hey, look, I was really thinking about, changing operating systems, or I was really thinking about trying hosted telephony or some sort of cloud-based backup. I could use this money in that instance, as long as it was related to my response to COVID-19 or a hurricane in my example. I could use it there, try it out, see what it worked like. And if I didn't like it at the end, it wasn't my organization's money that was spent on the experiment, which is kind of a bad way to say it, but it was, there are a lot of IT departments that look at it that way in healthcare. So moving on to challenges, the challenges for your customers are that some healthcare entities are suffering liquidity issues, and they may not be able to front the cash. So the example I like to use here is, I'm going to make a leap here and assume that we all get expense reimbursement from our organizations, right? So imagine if one of our customers needed us to fly to an EBC in California, and our organization requires us to spend the money on our credit card first, and then they'll reimburse me at the end of the month, right? So in this case, imagine you didn't have enough money to front the $600 flight, the hotel, whatever else might be involved, customer dinners, whatever else might be involved in that trip. If you weren't in a financial position personally to be able to do that up front, you may not take that trip at all because you don't have the money to do it. So when we look at what's happened to healthcare, especially around the suspension of elective procedures across the country, hospital systems are currently suffering liquidity issues, meaning the average hospital makes around on average a 3% margin, right? Across the board, about a 3% margin. If you're making a 4 or 5% margin, you're doing really well, and you're reinvesting into your organization, buying buildings, looking for other healthcare organizations to buy and do that type of stuff. But most healthcare organizations are sitting at a 3% margin. The majority, 70 to 80% of that 3% margin is made up through elective procedures. And when we talk about elective procedures, we're not just talking about, plastic surgery. We're talking about joint replacements. Any orthopedic surgery is considered elective. A personal story is that one of my family friends has a condition that causes his eyelids to droop. He can't even hold them open. His surgery was put off 2 days before he was supposed to have it because of the cancellation of elective procedures in my home state, which is Florida. So he's been waiting this entire time, literally not being able to hold his eyelids open, just to be able to have that surgery. The other surgery that's considered elective are surgical oncology procedures, so cancer surgeries, right? There's a little bit of back and forth about that one related to, do you really want to depress somebody's immune system or is with COVID-19, or is it better to run your chances on waiting a couple months until the COVID-19 has at least been partially mitigated through social distancing and then have the surgery? But back to my point, healthcare organizations have lost 80% of that 3% margin that they make annually in the last 2 years. And so back to my example of us and our expense reimbursement, if you're not liquid enough to pay for that EBC visit with your customer on your own credit card, you're in some pretty big trouble when it comes to being able to spend on the things that you need to. So in this example, healthcare customers aren't liquid enough to spend the money up front on the things that they need to respond to COVID-19. Therefore, they may not take advantage of the $175 billion that's available to them. So after this slide, I'm going to move into the CARES Act telehealth program. So I figured I'd stop there for a second, see if there were any questions about the healthcare funding piece of the CARES Act before moving forward.
So one question did come in. Are you a resource that we can leverage to help customers get an idea of best practices and how other firms are tracking towards CARES funding?
Yes, so I'm a resource for that. I would defer back to what Rob said. Just work through your channel managers and to get access to me. But yes, I I work with both direct customers as well as channel customers and channel partners to help them with the sale, pre-sale, or even just conversations with customers that are prospects.
Okay, and then another question, as there are government programs offering funding as you have listed, are there also savings associated with ROI, such as how telehealth investments may actually lower hospitals' practice insurance as well as in other financial areas?
So what I'll say is from an ROI, it really depends on the customer, right? So up until this point with regard to telehealth, right? Up until the COVID-19 pandemic, most healthcare organizations, public healthcare organizations, were not adopting telehealth. And the reason behind it was because there was no way for there wasn't a way for the physicians to bill for those services. So meaning to bill for a service, you actually have to have a billing code that's approved by CMS and Medicaid. Oops, sorry, we lost the deck there. That's approved by CMS and Medicaid in order to bill for procedures. So, for example, in my organizations, we didn't ever really. Sorry, I'm trying to get this thing up here, pop down. But my organization, we didn't really have the opportunity to implement a whole lot of telehealth because we didn't have a way to get reimbursed for it. So. So yes, there are there, and that's why it depends on the customer's ROI, because it just, some don't value it and some do. I'm not sure what happened to my slide deck here, but let me try and get this back up. All right. I think I've got it back in play here. Can everybody see that again?
Yeah, if you just want to click present, and then we should be good. Yep, we're good.
Okay, awesome. Sorry about that. Any other questions before moving on to the telehealth piece? And did I answer the one well enough?
I think we are good for now, so you can go ahead and move on to the next section. Awesome.
So the second one that I mentioned before was the CARES Act telehealth program. This is really the $200 million. This has a lot more flexibility than the original, or than the first one that I talked about. So when we look at who's eligible, you'll see there's a long list, right? But the key here is that it's still nonprofit and it's still public eligible healthcare providers that fall within the following categories. I'm not going to read them all for you, but I think when you start to look at it, the ones that stand out for me, where telehealth can really be leveraged and where it's being leveraged today are around mental health centers, local health departments, community health centers, as well as post-secondary education institutions. So if you're thinking about your university affiliated hospitals, that's where they would land. And we'll jump to the next slide here and kind of talk through this. So here's how it works. The eligible entity that we just referenced on the other slide there, they apply for approval via the FCC. Once approved, the entity then submits monthly for reimbursement for the FCC. A couple points here about the way that works. So I think it's either 5 or 7 in some cases questionnaire on the FCC website that they fill out. Right up front before approval, the FCC wants to see quotes from partners or vendors or manufacturers included in what's being requested. And then the FCC approves it on a rolling basis. One point here that I'll make is that you can get really creative here. So it's not just about buying telemedicine or telehealth devices. It's also about what goes into delivering that telehealth. So an example that I'll use here is one of our customers. They asked for $387,000 out of this $200 million, and it included telemedicine software licenses, iPads, telemetry devices, computers, and screens for patient monitoring stations, security cameras. It can be patient devices as well. So when you think about telehealth, there's the component that the physician or clinician is on, and then there's also the component that the patient is on in their home. So it can even include those devices. I would say the main point there that I'd like to make is that people are getting very creative. The difference here another difference between this and the prior that I talked about is these are specifically for technology and services associated with telehealth. So that remote patient visit, it can be operational expenses that are associated with bandwidth. It can be operational expenses that are associated with staffing. It can be capital expenses associated with the acquisition of hardware or software, operational expenses associated then with services that are provided. So if you think about some telehealth as a service, there's a large component of operational expense and a smaller component of capital expense for the customers. So if I put my customer hat back on, I view this as a good opportunity to offset some of the costs that I was considering for the implementation or expansion of telehealth. So going back to my hurricane example, right? If I already have telehealth solution in place, whether it's like an Amwell or Video telehealth solution, I might use this as an opportunity to buy licensing as well as hardware associated with it. Or if I didn't have something in place, I might use it as an opportunity to experiment around with one or both of those solutions and play with house money instead of my own money to do it. Again, it's the same challenge here for your customers, right? So they front the money and then they seek reimbursement. The difference here is that the reimbursement occurs monthly until the money runs out. The prior example I gave of the 175 billion, in some cases with hurricanes, one case it took us 2 years to get money from the federal government, but in most cases, I would say it averaged about a year to get reimbursement from the federal government. So if you can't hang out there for that long with that much cash laid out, that might be another challenge. In the case of the telehealth program here, at least you know that you're putting your money on the line for a month until you get reimbursement. Any questions here before I move on to a different topic?
Yes. So do you know if private addiction centers are eligible for the 200 million?
So the way that I interpret this, and I'll bop back one slide, is that they are not, but unless they're providing care to migrants. So, but the FCC website's got some pretty good FAQs about each of these 8 categories and what they mean. But based on this first line here about being nonprofit and public eligible healthcare providers, if they fall within the public eligible, which they may, then they could fit in. What I found is I've talked to customers about this, they know whether they're eligible or not. So usually it's just introducing the topic to say, hey, what are you doing about telehealth program? Are you planning to access any of that money for care? And they'll either say, no, we're not eligible, or they'll say, yeah, we just need to figure out what the right solution looks like.
Okay. The next question is, can CBTS help customers apply for the 200 million, and do you just apply through the FCC website?
So CBTS can help on the fringe, but we are not allowed, nor is anyone else, to fill out the survey or fill out the application for the customer. So we can help with solutions, architectural design, those normal components that typically a VAR could help with, but we can't physically help for the help with the application.
Okay. The SLA from the government is 30 days.
Did you say SLA?
Yes, SLA.
So I assume that means to respond back to know whether you got it or not. It's on a rolling basis. The FCC site said they meet daily. The only other restriction they put on it is Um, while it's not a hard restriction, they said it's hard to see us giving any single entity more than $1 million. So it's on a rolling basis. There's money already starting to go out. That started, I think, about a week and a half ago from this 200 million. That's really the only restriction or SLA that I'm aware of, which is they approve it on a rolling basis daily. You know, obviously, if they get thousands of applications, it's going to take many days for them to get through that. If they only get 5 applications in a day, it might not take that long to get through it.
Okay. And then what infrastructure can CBTS provide besides Cisco WebEx for healthcare? Also, how fast can it be deployed?
Yeah, so a couple things. So we can provide telepresence devices, right? So anything within anything within the like Cisco GX80s, cameras, to remote access points, to software related to WebEx, to end user devices that might be used. You know, if you're not wanting to use a Cisco telepresence device and instead are wanting to use laptops, software licensing associated with those things. We've got, wow, a lot is what I'll say there. And what was the second part of the question?
Sorry, the second part was also how fast can it be deployed?
So how fast? That's a good question. I would say that it depends on the supply chain. In the beginning of the COVID-19 response, we had to be pretty resourceful in multi-source hardware. I think that, you know, given that a lot of it is coming, or at least components of it are coming from China, you know, they had their own issue with coronavirus and COVID-19 that's kind of cascaded. So it's supply chain when you talk about how fast. And where I was going with the initial part was we were asked to find to send remote workers home and support telehealth. We were asked to find 1,000 Aruba access points, and we had to multi-source it from 3 different sources just to come up with that 1,000. So on the hardware side, it really depends on what the supply chain looks like. On the software licensing, and really what we're seeing from a lot of, or what I'm seeing from a lot of our healthcare customers is they're looking for speed to value. So if it doesn't involve, the less it involves their people and the less it involves waiting on a hardware supply chain, the more likely they are to adopt it. So when you look at things like software licenses or cloud-based licenses, they're starting to consume that on a greater, on a much greater level than before, just because it doesn't require one of their people to stand it up and it sits separate from their own environment. So hopefully that answers that question. A little bit harder on the hardware side, depending on sourcing. And if it's not hardware related, a little bit easier. It's in its software or cloud-based licensing very quickly.
Okay. The next question, is this something you apply for and then get reimbursed, or are you submitting on a monthly basis and hoping to be reimbursed?
So you apply for it, and so we'll see. You go fill out the application on the FCC website. They tell you whether or not you're approved. If you're approved, then you would begin spending on those solutions. And then at the end of the month, you would apply for reimbursement, and they would reimburse it because it fits the approved solution. And then the next month, you do the same thing. So in a typical view of this, you would have your hardware costs up front, right? You would spend that in your first month, plus your first month of OpEx. And then in the second month, you probably wouldn't have many hardware costs left. It would just be a continuation of the operational expense that it takes to host the solution or manage the solution.
Okay. Would for-profit long-term care facilities considered a public eligible healthcare provider?
It depends on the way that they were configured, right? So when you look at, and I know the example I'm going to use is not a long-term care facility, or skilled nursing facility, but when you look at the for-profit hospital systems, like community healthcare systems out of Franklin, Tennessee, and HCA out of Franklin, Tennessee. You combine those people have those two organizations have more than 500 hospitals in the country. Both of them received money from the first bucket of money, the 175 billion, but not from the telehealth program that I'm aware of. So I think it just depends on the way the organization is incorporated.
Okay. Will CBTS extend a line of credit to the client while they start getting reimbursed by the FCC?
Well, that's a good question. Rob, if you're a better person to answer that, why don't you jump in? Otherwise, I'll just give my opinion.
Well, why don't you go first and I'll confirm it.
So the way I was gonna answer that is, I don't believe we would. It doesn't make sense for where we are right now.
Yeah, I do know that some of the OEMs have programs in place for COVID in their financing, and so we can assist depending on who the OEM is and help run those traps down. But other than that, I think Dustin, I think you said it well.
Okay. That's all of the questions for now. You can continue.
All right. Thank you. So we're going to move into remote access clinical equipment, which is affectionately called the R.A.C.E kit, or it could be called the remote ambulatory care equipment. However you want to look at it, but imagine this, right? So hospitals, when a pandemic occurs, a non-pandemic, for example, one of the healthcare organizations in my past, we used to set up these remote tents in the middle of the Daytona Beach International Speedway for the 2 NASCAR races and the 1 motorcycle race they had each year. And it was really just a way to bring the care to the patient. In the case of COVID, I'm sure you've seen many pictures or videos of tents being set up outside of hospitals, whether they be in the parking lot, a parking garage, somewhere like that, for screening of patients as they try to enter the facility, or for screening, do you actually have coronavirus antibodies, or do you have coronavirus? Currently, they've had these screening tents as well. So the R.A.C.E kit allows hospital systems and other entities, as you'll see here in a second, to take their existing tent and make it completely remote. And really the solution or the problem that it solves is that those tents that you see on hospital property and parking lots or parking garages require land-based connectivity. So the reason they're in the parking lot is because the healthcare IT teams can just run a simple Cat5 cable across the parking lot or through the grass into the tent to a switch and power the tent for connectivity into the electronic medical record. Well, what CBTS created and deployed with one of our customers, by the way, was a way that we could take those tents, the healthcare organization could take them anywhere they wanted, because through SD-WAN solution, Velo Cloud, as well as cellular connectivity, we could connect that tent back into the data center so that those care providers could either provide screening or access data center resources like the electronic medical record or any other type of resource they may need that's traditionally only accessible via hospital-based LAN. There's the second slide here will show you the actual what's in the R.A.C.E kit. But what I want to talk about is the opportunity for customers first, before we look at the next slide. And so I look at this as, and I'm sure the options are endless, but 2 of them are healthcare and state, local, and education, right? So healthcare and government entities are talking about, how do I bring my services to the patient, or how do I bring my services to the community? And they all have these tents, and they're for pandemics, they're for hurricanes, they're for expanded care settings, they're for screenings. They use them for all kinds of stuff, right? So what I see as an opportunity for our customers, and really a way to get them thinking differently, because today healthcare customers are thinking about the first bullet point there, pandemic screening tents. But if you start thinking about getting them to think about it a little bit differently, these tents can be used to deliver care to the patient. So imagine the second bullet point there is Department of Health screening events, but it could also be your healthcare customers screening events or education events. Imagine being able to plop one of these tents in a Target or a Walmart parking lot, or pick your local grocer's parking lot and do blood drives with connectivity back to the electronic medical record, do screenings, evaluate diabetes type education and screenings. And then as you move out of the government, the state and local, as well as the healthcare, you start looking at sport venue points of care, right? How many entities send an ambulance or multiple ambulances to college level sporting events or to high school level sporting events when you could just plop this tent down, leave the ambulance to be able to transport, but use the tent to screen and handle, the bumps, the bruises, the, drunk guy falling down the stairs at the sports venue kind of thing, who's got some bumps and bruises, but doesn't need to go to a hospital, or concert venue point of care, same deal, right? Having these outside where these mass gatherings usually collect before entering, whether it be a sports venue or a concert venue, having these tents there gives them not only shade, but privacy, access back to the hospital system. Because today, and what I should say is in the past, the way that we would use this, I mentioned deploying this to the Daytona International Speedway for the races. Our doctors and nurses just wrote on paper, and when they got back to when the event was over and they got back to the main setting, we paid people to do data entry and put that stuff into our electronic medical record. So it saves that. The other issue that creates is that you don't have the patient's prior history if they're a patient that goes to your health system. So as you're looking at treating them because they fell down the steps, maybe they weren't drunk, but maybe they've got a history of vertigo or something else that you wouldn't know unless the patient could tell you. But you would know if you're connected back to the data center through VeloCloud and cellular connectivity. I kind of hit on the last bullet point here, which is the challenge for your customer. The challenge really will be getting them to see the broader value, to think outside the box. I'm sure some of you could name other applications that I didn't even touch on and probably haven't thought about for a tent that has connectivity, cellular connectivity, and VeloCloud riding over that connectivity to provide secure access back to the data center. So the challenge for you and your customers will be getting them to think more broadly about the solution and its applicability. So without further ado, these are the components. So I mentioned that the customer brings their own tent. We can drop ship this entire package, including the generator, rack mounted UPS, VeloCloud endpoint, 24 port switch that's managed, LTE modem, access points, as well as voice over IP phones. I think it comes in 3 kind of roto molded boxes for easy storage and transport. And the way that I would have used these at my old organization it'd be called the Hurricane Kit, and they would be stored by facilities somewhere in a warehouse or in another building. And we would pull these out whenever there's a hurricane and we need to start to prepare for our ability to remotely treat patients or screen patients within our own facility. So I'll pause there. That's really the last slide I have before I turn it over to Matt. We got about 10 minutes left for Matt to go through a couple slides about CBTS, but I wanted to see if there were any questions about this.
Yes. So I'm not sure if you can do this off of the top of your head, but can you provide budgetary pricing for R.A.C.E for just simple connectivity and maybe a couple of VoIP phones? And will the R.A.C.E kit be billed as one bill or multiple bills from CBTS and say the LTE provider?
I can address that, Dustin. This is Matt. Let me turn my camera on here. So yes, we're open to using parts and pieces of this. One of the things this has come out of, we've done similar things with like construction companies, where a construction company wanted to build a trailer of the future. but be able to deploy it on flexible terms. Maybe a trailer sits one place for 6 months or 12 months. So we're open to adapting parts and pieces of this. Now, the kit that it sits today has been basically priced as a 12-month managed service of most of the components in there, then plus a management fee, a project management fee, and we're sharing those same commissions with the partners, et cetera. So to go into more detail with that, we're probably better off taking this offline, get a hold of your account manager, and let's just set up a quick WebEx. But this kind of flexibility of using parts of our SD-WAN product, the NAS product, the UCAS product, access to wireless networks, et cetera, we're more than open to figure out how we might adapt parts and pieces to have some particular solutions for your customer.
And I can also send out the pricing when I send out the copy of this deck and our recording as well for everyone to review. And then, Dustin, there's another question for you. As a customer, how did you select CBTS as a vendor/strategic partner?
That's a good question. So I'll give the brief answer. I worked with a partner, KPMG, to help select my unified communications partner. I was looking at your typical big boys in the nation, and KPMG said, we really think you need to look at this other company, CBTS. They're doing a lot of really good things and have some really smart engineers. And so my first meeting with CBTS, they brought engineers and not salespeople. There were salespeople there, but from the customer perspective, every single question that me or my team had were answered in that first meeting. I don't think there was a single follow-up item for the CBTS sales and account reps. So looking at the engineers that they brought, the solution they brought, and KPMG's backing of them was significant to me. And then I'll say the downside of the people that I was evaluating against CBTS were that they wanted to make whatever I wanted. And I was really looking for somebody that was an industry expert that would tell me things I didn't know versus just say yes to the things I wanted. So in a nutshell, that's how I selected them. And then over the 2 years that I was a customer, just a constant state of outperforming my expectations. And when they didn't, fixing it quickly and acknowledging it was just a breath of fresh air to what I'd been dealing with. Made me want to go work for them.
Okay, so those are all of the questions I have for now.
Okay. Matt, you want me to drive into your slides there?
Sure, go ahead. I think we've just got yeah, keep going. Just go a couple more here to the 4 pillars. Keep going through. Yeah, there you go. So, oh, we lost it. There we go. What I wanted to add here, there was a great question. I was making some notes as you were talking, Dustin. And somebody asked earlier, can we use your expertise, right, in helping our relationships with healthcare? And that's exactly how we've started working with Dustin. We've got a deal right now that we're working with a 30-location hospital out on the Central East Coast. We first got brought in by a partner to talk about SIP trunking. It's about 600 concurrent calls of SIP trunking. And as we started to talk to them, the opportunity progressed, et cetera. We said, we'd love to bring in, we've got a healthcare vertical. We'd like to bring our team lead in, kind of the practice CTO, practice manager, and talk to you a little bit about, not only the technology, kind of our telecom, the SIP trunking we had, but also just our bigger practice in general. So Dustin came in, met with the customer, and that then proceeded to expand into them now wanting to look at a 30,000 seat UCAS opportunity. So I think for us in the channel, as we use Dustin, oftentimes we come in and I'm used to just talking like a service provider. I know my technology, I know my service provider perspective. I don't have the healthcare perspective. I don't necessarily have the language, the context on some of these bigger issues. And so Dustin absolutely wants to engage with us in the channel here, opening up opportunities on the healthcare side. for really kind of any of our product mixes and for actually your relationship in general, right? And I hope some of you have heard this statement, but we spend a lot of time in the channel talking about how do we make you as a partner heroes. And so Dustin has offered for him to come in and help his expertise to come in, meet with folks, and to help further your relationship in some of these. Now, we have to be careful of his time, right? And that's why you got to go through channel manager. You got to be careful of that because we use a lot of his time across the entire CBTS. But that's the first thing I wanted to talk about was that Dustin has been a great addition for us on the channel. Coming right into opportunities, being able to expand them, in this case, from simple SIP trunking to what it looks like could possibly be a larger UCAS opportunity. That was the first thing I wanted to kind of mention. Other note, somebody asked about, can we bring technologies other than Cisco to the solution as we talk about using any of these funds, et cetera. In the channel, we have oftentimes, as you guys have gotten to know us here, focus on these kind of 4 pillars that you see here. Kind of our telephony and collaboration practice, the Meraki, what we call our network as a service practice, the SD-WAN, the multi-platform cloud security. I want to mention a little bit about that. But we are expanding how we're taking a lot of our services into the channel here. And again, we have to be careful of the size of the opportunity. We're probably not the right partner to sell 2 switches to somebody, but we have a wide variety of products. Whether you're talking, Dustin mentioned Aruba, HP, IBM, Red Hat. It's a huge list. We're $1 billion a year of R&IT services. So if healthcare folks are needing solutions to get some of these funds in the care or telehealth, it's more than just Cisco solutions that we could bring to bear there. The other thing I wanted to kind of talk about here too is this 4 pillars that we've talked about here. And in a lot of ways, we're starting to talk about this as 4 pillars plus, right? Some of you might not be aware that we've added a multi-platform cloud security practice. That's really new to the portfolio for us in the last 6 months. And this came out of the work that we've done on the SD-WAN side. As people look at deploying SD-WAN solutions, it's forcing them to relook at how they handle security, right? Maybe oftentimes they were taking security back to a common headquarters or data center. Are they looking at maybe more decentralized security? And then this kind of concept of let's talk about moving security to the cloud. Moving security to the cloud takes your kind of attack plane and day 0 plane away from the front door of your office, right? And just like people are wanting to move their UCAS infrastructure to the cloud, and we see that with Meraki. People are saying, I want to buy some new LAN infrastructure, but could that be cloud enabled? Well, the same thing is about moving security to the cloud. So Checkpoint for us, we've done a number of deployments we're a big Palo Alto shop, by the way. We've done a number of things with Palo Alto and Palo Alto's Prisma product. Done a number of things with Checkpoint, with Zscaler. But Checkpoint, who's been one of a Gartner Magic Quadrant leader for quite some time, released a cloud product going back 18 months or so ago. And we're actually the first service provider to put that in our managed service offering. We'd love to talk to you about that. We also, Cisco has expanded their umbrella line to also include a secure web access gateway. So we've got a lot of information in the cloud security side. But the other plus part of this that I want to talk about, and we've just got a minute here left, is that we have a deep, and this was in Dustin's slide, some deep expertise in cloud consulting, being able to help people move applications from headquarters or data centers into the kind of new world of AWS, Azure, Google Cloud, et cetera. We've got deep expertise kind of on the IT and staffing area. We do a lot of work for helping people do staffing. Our application development team has expanded greatly over the last couple of years. So you guys as partners out there, I hope you see here that we're starting to expand kind of a little bit our scope and reach and what we can do, and get with your account manager. We'd love to explore some of this stuff. So thank you.
Thanks, Matt. One reminder, thanks everyone for joining. If you remember, this is a setup for a customer-based webcast that we'll be doing. So obviously we'll kind of take the partner part out of it. And really just focus on how we help customers that you can invite your customers to and tag your referral to them, or they can attend and tag you. So that is on May 20th at 1 p.m. Eastern. Contact your channel manager and we can make sure that they help get that scheduled for you and get your customer those links. With that, we'll send out this presentation and recording. Really want to thank Dustin Leak, Matt Douglas, and Gabby Scott for their help on this, and all of you for attending. Thank you very much. Have a great day.
Thank you.
Thank you.